हाँ भाई. Hello.
Hi Vivek. Hi Vivek. Did you have a word with Dr. Gulia?
Just I'm calling him. Can you hear me?
Yeah, I can hear you. I can hear you well.
Okay.
Okay.
ठीक है. 1 second. सर को मैं just call कर ही रहा हूँ.
Mute yourself and call.
Okay.
Welcome, Dr. Gulia and Dr. Vivek. Hi. So I have made you a co-host each, so you can control your audio and video. Dr. Ashish, you want to try and check your slides whether they can be shared or not, sir? You can try to share your screen once. Sir, is that the Bombay
Hello, sir.
background?
That's my house.
Achha, how?
Should be okay. Looks good.
Yeah. Looks good, sir. Sure. So what we do is we introduce the topic, we introduce the speaker. We have a short quiz which Vivek has prepared, 5 questions. We usually give the answers at the end of the talk. The purpose of the quiz is that you will cover all those questions during your talk anyways, and just to create some interest. We still don't have a sponsor, so we don't have any prizes. But still, it is in the pipeline.
No, I'm sure you have Shubham Garg.
Problem with the
He's more than a
volume.
sponsor.
Can you hear me, Shubham?
I can hear you, Vivek. I can hear you. Okay. Sir, it is 8:28. We'll start exactly at 8:30. Okay, sir. So
I'm
Wait.
Perfect. So may I now request you to switch off your mics and camera, please. Thank you. So you can stop sharing as well, sir, Dr. Ashish.
Yeah. Oi, बच्चू
Hello, Shubham.
Hi, and good evening. It's 8:30 on a Wednesday evening, so it's the Cancer Academy time. And today, today is happens to be a 14th weekly lecture. We started uh, in the month of June, and thanks to pandemic, we have discovered Zoom and so many great faculty who have agreed to come on this platform and go beyond teaching, go beyond their daily routine, and do this not just for us, but for all the students around. And as we move deeper into this, we are going into more and more niche specialities. We are going into more and more niche topics, and also our speakers are becoming more and more exclusive. So last week we heard Dr. Ravi Kannan talking about what inspires him, and from that we have moved on to something which is we don't hear very often, but something which we come across very commonly, and which is about management of bone tumors. And today we are going to cover a broad overview on the aspects of management of limb salvage or management of bone tumors. And Dr. Ashish Gulia, who's a professor of bone and soft tissue services at Tata Memorial Hospital, has been a great mentor and a very good friend. And he has helped me actually decide not just this topic, but he has also helped us create a set of topics to cover musculoskeletal oncology with Cancer Academy. And you will see as we go along this program how Sir plans to cover all 5 or 6 topics, which covers radiation, which covers medical oncology, and it also covers surgical oncology topics. I have also with me a very dear friend, Dr. Vivek Verma, who has been a fellow at Tata Memorial Hospital and who would be moderating this session, as it might be a bit bone heavy, so I need a hand. And Vivek has been a good friend and has been over the past 4 years taking care of our bony needs, whatever they might be. So with this, may I now ask Dr. Vivek to come in and please conduct the quiz. This quiz, as the norm, are 5 questions. Vivek, can you switch on your camera and mic? Yeah.
Uh, my camera is open, I think.
Yeah, Vivek. Just okay. So Vivek, I'll just start the quiz, read out the questions. Okay.
Right.
And let me just introduce the quiz for everybody so that they know what we are going to do. People who have been on this program, they know how the quiz works. The quiz is a WhatsApp based quiz where we expect all of you to answer question in one message only. So this is our WhatsApp number, 9953621242. Uh, and we request you to send your answers in this format. Write your name, your institute name, and there are 5 questions with 1 correct answer. It's a multiple choice question, and we request you to, at the end of those 5 questions, which Dr. Vivek is just going to read out, please send your answer in a single WhatsApp at this number, and with the correct sequence of answers. So Vivek, go ahead. These are the questions that you sent us. Okay.
Right. So thank you, Shubham. And I think this is a great effort by the Cancer Academy to start and in this topic of orthopedic oncology. And just a few words, because I feel this is a great day for me, because when I joined in Tata Memorial Hospital, my first posting was with Shubham Garg only, when we were there together. And it's a great honor to welcome Professor Ashish Gulia, sir, with whom we have learned the basics of orthopedic oncology. So let's start this program with the first question. So what is an absolute contraindication for limb salvage surgery? The answers are pathological fracture, infection, involvement of vessels, involvement of nerves, or none of the above. So just see that it is an absolute contraindication, right? So the next question is, there is a 25-year-old boy with Ewing sarcoma of the distal femur and bilateral lung mets with 4 on each side. So what will be the treatment option? Is it a best supportive care, or we start with chemotherapy, assess, and then plan for local treatment? Or we give, since there are lung nodules, we plan for palliative chemotherapy followed by radiotherapy? Or just give palliative radiotherapy to lung and the bone. So the third question is, a 20-year-old lady with parosteal osteosarcoma of distal femur with vascular encasement. So what will be the plan of care? Should we plan for amputation? Should we plan for chemotherapy followed by limb salvage surgery? Should we plan for upfront surgery, whatever it is, either limb salvage or amputation, or chemotherapy followed by radiotherapy? Fourth question is, what is true of Mirrell's scoring criteria? This is an guiding indication for fixation of spinal fractures. Mirrell's determines the risk of developing a pathological fracture. Mirrell's determine the risk of recurrence after limb salvage surgery. A Mirrell score of less than 5 guides that it necessitates a prophylactic fixation. And the fifth question is, young boy, 6-year-old with non-metastatic Ewing sarcoma of proximal femur. So which is not the local treatment options? First, rotation plasty. Second, expandable prosthesis. Third, radiotherapy. Fourth, hip disarticulation. Fifth, curettage and bone grafting. So I think we have done these questions and you can send the response on the number provided. And I hope has kept some prize for that.
No, Vivek, we are still waiting for a sponsor. But please, I request you to send your answers onto this number, name, institute, and all the 5 answers as a consolidated message in the right order on this number, 9953621242. I'll put it in the WhatsApp on the chat box also, so you can send it there. And with this, I don't have a drum roll to invite Dr. Ashish Gulia, but I'll stop my screen share. I'll be on mute because I'll be mute spectator now for the what is going to follow. The floor is yours, Dr. Ashish. Thank you so much for doing it. Sir, your mic is muted, sir.
Yeah, give me a minute. I'll set everything up.
Okay, great, sir. Just a quick reminder also, sir, that this video is live on YouTube also, and it's being recorded. So we put it in the archives of Cancer Academy on the YouTube channel so that students can go in and log in again. And if they want to create an answer, they can refer back to this talk.
Don't worry, I won't tell them the secrets of your stint. So thank you so much for inviting me to this great platform. Thanks to the Cancer Academy, especially Dr. Garg, who's been kind enough to remember me after years and invited me to speak something which I practice day in and day out, that is musculoskeletal oncology. I get you greetings from this great institute where I work since past 13 years almost. And the first Society of Musculoskeletal Oncology Tumors, that is Indian Musculoskeletal Oncology Society, where we all come together, whoever is involved in the treatment of bone and soft tissue tumors, to make a difference in the standards of musculoskeletal care in the country and subcontinent. Me and Shubham discussed in depth about what topic we should discuss. Initially, we were thinking that we'll speak about limb salvage. Then after a detailed discussion, I proposed that we should have a series of lectures where we can cover sarcomas, so that it is beneficial as a multimodality lecture series, rather than just showing you what kind of surgeries we do and just satisfy as a surgeon's ego. So what we thought that we will first in today's session, I'm going to speak to all of you about managing malignant bone tumors. I'll give you a broader perspective about it, showing that how multimodality management is done to get optimum outcomes in malignant bone tumors. In the weeks to come, as and when we get the slots from Cancer Academy, we'll invite who's and who's of sarcoma management from different specialties, across India, which will talk to you about all the principles, including use of radiotherapy, use of chemotherapy, and maybe a few more surgery lectures, so that we cover all sarcomas together. So without wasting any further time, first we need to understand that when we are trying to treat any bone tumor, and I think the most essential and the first step is to get the correct diagnosis. And this is not just the oncology, but it serves in every field, that if your diagnosis is correct, 3/4 of your remedy is already done, as said by Mahatma Gandhi. And why it is so important in bone tumors. And the reason is very clear in front of you on the screen, where bone tumors are basically divided into malignant tumors and benign tumors. If you see specifically, the kind of treatment which you offer to a benign bone tumor will be completely different to the multidisciplinary management you will be offering to a patient with malignant bone tumor. In benign bone tumor, you would try to conserve as much as of the bone, and you will do function preserving intralesional surgeries, which are the mainstay of the treatment. While treating malignant bone tumors, surgery alone cannot help, and you require help from various other subspecialties so that your outcomes are optimized. And hence, it is very, very essential that your first step is to get a correct diagnosis. A correct diagnosis essentially built on 3 pillars. Pillar of history and examination, where you as a clinician examine your patient, take a detailed history. The clues which you get from your history and examination guides you to do the appropriate imaging. And in bone tumors, it will be radiographs and MRI, and I will explain you in detail what all you need to look at there. And then once you have a clinical radiological diagnosis, you need to confirm it with the help of a biopsy, so that you have a clinical radiopathological diagnosis before you embark onto any kind of treatment, whether it is surgical, whether it's chemotherapy or radiotherapy. So as I said, the first step is to take a great history and to do a good clinical examination. I'm just showing you in brief that when you do clinical examination, you need to look at the limb completely. You need to look at the size of the swelling, its progression, how fast or how slow it's progressing. You need to look at its location and the site, and how big is the swelling, how many compartments it's involving. You also need to take a detailed history of the previous treatment and examine the limb for any deficit which would have happened in the previous surgery or because of the tumor which is present. Once you have assessed all these parameters, then you decide clinically whether you will be able to salvage this limb or not. Once you have completed this clinical examination and you have a clinical diagnosis, whether you are dealing with a benign pathology or an aggressive pathology, and in aggressive, probably what kind of pathology, depending upon patient age, site, and location, you will start doing appropriate imaging. In the right upper corner of your slide, you can see a gamut of investigations which I have written. Now, these imaging modality will help you to clinch the correct diagnosis. In addition to that, they will also tell you whether the disease is spread to the other parts of the body or not, and what is the local extent of the disease, so that you can plan your surgeries carefully. So as depicted in this slide, that apart from diagnosis, imaging is very, very essential to plan your staging, to plan your biopsy, and also to plan your final surgical plan. And that's why doing these appropriate imaging is of utmost importance. When we speak about radiological pre-treatment evaluation, we always divide investigations for local staging and distance metastatic workup. The gold standard for local staging of any bone sarcoma will be the plane radiographs in 2 perpendicular planes, which covers the entire bone, including the joints above and below. For further characterization of the disease and to look at the exact extension of the disease, MRI is the best possible investigation available, and I will tell you the reasons why. When we talk about the distance staging, lungs are the most common site, and here you have CT scan of the lungs, which will guide you and tell you whether you have disease available there or not. Then you have bone scan, because the second most common site for the distance spread of malignant bone tumors is bone, and hence you need to scan the complete skeleton for doing the complete staging workup. Now, a lot of people ask me that how do you read X-ray and what all information you can get. So this is a slide which is very important for the students, not just for the theory, but also for the practical examination. Whenever you assess a lesion on a plain radiograph, you note down these 4 important parameters. And if you categorize, or if you try to read any X-ray which you get in your clinic and try to put them or characterize them into these 4 parameters, almost 80 to 85% of the times you will be able to reach a probable correct diagnosis. So the first thing is you need to assess the type of the lesion. Now you look here, you have a lesion which is lytic in nature, which is present in an immature skeleton, as you have physis open. You have this lesion which is going right up to the subchondral bone or the epiphysis. There is expansion of the bone also there, and there is trabeculations. Okay, so this is a lytic lesion. This is the area where you see that you have a sharp demarcation between the normal and the abnormal bone. So essentially it means that you can take a pencil and draw a line here. What it means is that you are dealing with a slow growing pathology, and bone itself is good enough to stop this and throws a lot of sclerosis at the periphery. Again, shows that the pathology is not very aggressive and moderate or a benign pathology. Very important sign also to see the periosteal reaction. Now take your attention to this X-ray here. You have an osteosclerotic lesion, which is in the upper end of the tibia. You have a lot of ossification in the soft tissues, and you have this bizarre periosteal reaction happening all around. You also have a probable Codman triangle also happening here. So when you have such malignant periosteal reaction, they tell you that you are dealing with a lesion which is aggressive in nature and growing very fast. And here also you will realize that you will not be able to tell where the lesion is ending, and it is extending right into the marrow, and again shows the aggressive pathology. Then we talk about the matrix of the lesion. I showed in this X-ray that you have an osteosclerotic lesion. That means matrix is something, a substance which the tumor produces. Now, so every tumor produces some matrix, but some matrix are visible on a radiograph and some are not. So if you see this X-ray, you have a lesion which is a mixed lytic and an osteosclerotic lesion. Okay, so this kind of matrix it says. If you look at this one, you have a very sclerotic matrix. That means it's a bone producing tumor. But if you look here on the third one, you do not see any matrix on the radiograph. That doesn't mean that the tumor doesn't have matrix. Tumor has matrix, but it is not visible on the radiograph. Okay, so if you have a osteoid producing matrix, if it is benign, it may be osteoma. If it is malignant, it will be osteosarcoma. Tumors which are cystic in nature, like for example, unicameral bone cyst, aneurysmal bone cyst, or giant cell tumor of the bone, they will not produce a radio opaque matrix, and hence they will look like they do not have matrix. Typically, fibrous dysplasia will have a ground glass matrix because there's a lot of fibrous material in there. So now, whenever you get any X-ray, you try to assess that lesion, try to categorize them into these 4 points, and I'm sure you will be able to diagnose them correctly. Moving on further, as I discussed with you that the MRI is the best possible investigations for local staging of any malignant bone tumor. And the reasons are very specific. If you see any X-ray, you may not be able to tell the exact extent of the disease, but MRI, as shown in this picture, that the disease is going right till here. And as you see in this picture, the disease extent is very clearly shown here. MRI, especially T1 weighted images, are the gold standard to look at the intramedullary extent of the disease, which may not be very obvious on a CT scan or on a plain radiograph. The periosteal extent of the disease is also pretty prominent on MRI. The relationship to neurovascular bundle, as you can see in this transverse section, again is shown very nicely on MRI, which may not be so clearly visible on a CT scan. And obviously the involvement of the joint or pathological fractures or extraosseous soft tissues are much more prominent in MRI, and hence MRI becomes the investigation of the choice, and it is not CT scan. We already discussed about disease spreading to the lungs and where we need to do the CT scan of the chest. A non-contrast CT scan of the chest with thin slices, approximately 3 millimeters, is good enough to pick up any metastasis from malignant bone tumors, and you do not require a contrast CT scan. Bone scan, as I discussed, is again a good modality to look at the skeletal metastasis. Nowadays, people talk about PET scan, which is a new modality. So basically, it's a single stage investigation modality which can stage your tumors by not doing separate two investigations. But obviously, we know that there is cost related to it, and hence it should be used pretty judiciously. And this is one of the examples that how a PET scan has shown disease not just in the bone, not just in the lungs, but also in the lymph nodes in a case of osteosarcoma, and adds much more value to just doing a bone scan or a CT scan of the chest. Now, the third pillar which I spoke to you about diagnosing the disease correctly was the biopsy, and which leads to confirmed histopathological confirmation, and after which you can start treatment. But if you need to just remember one slide from my presentation, this is the only slide. What it means is that how typical the imaging looks, how perfect or senior or mature you are. But unless and until you have a biopsy to prove your clinical radiological diagnosis, you should not start on any kind of treatment for these aggressive looking lesions, because there can be dilemmas and differentials, and there can be wrong diagnosis. So whether you need to start neoadjuvant chemotherapy or to do upfront surgery, please make sure you have a histopathological diagnosis. In a few tumors which appears benign, where we are planning to observe, we may not do biopsy, but those patients are on close observation, and hence, even in them also, if you need to start any sort of treatment, you must prove the histopathology and then do the treatment. Now, all these things which I discussed with you has to be done in a proper sequence, and there are very specific reasons to it. As I discussed with you earlier, you need to take a good detailed history, which will tell you whether the disease is fast growing or slow growing, which again tells whether you are looking at an aggressive lesion or you are looking at a non-aggressive or benign lesion. When you do the clinical examination, again, you confirm your findings, which again guides you towards a particular path, whether this lesion is an aggressive lesion or a non-aggressive lesion. Till here, you do not talk about the diagnosis, because you may have a lot of malignant bone tumors which will have overlapping clinical history and clinical examination. You may have infections of the bone which will also have overlapping history and clinical examination. So till here, you talk about whether you're dealing with an aggressive lesion or you're dealing with a non-aggressive lesion. This clinical examination and history will guide you through the appropriate imaging. If you do not take proper history, if you do not do clinical examination, you may be doing unnecessary investigation, or you may be under investigating your patients, and you may miss the correct diagnosis. Now, doing imaging is again very important before doing the biopsy. Biopsy is actually a very, very important procedure, and maybe if time permits in any of the further classes, we can discuss biopsy in detail. Now, imaging is a total guide to the three-dimensional anatomy of the disease. Biopsy is actually planned in a way that it should not hamper your final treatment. So the biopsy scars are put on the same incision lines where you will do your final surgery. What essentially it means is that you will be deciding what is your probable diagnosis, and based upon that probable diagnosis, what sort of probable surgical treatment you will be doing and what approach you will take, and on that approach, on that incision, you will be doing the biopsy. So essentially, when you are planning for a biopsy, you would have already planned for a final surgical treatment, and hence imaging is very essential to look at the lesion carefully, to decide which part of the lesion to be biopsied. As sarcomas are heterogeneous, you have a lot of necrosis also present. You want to locate which areas you don't want to biopsy and want to avoid. So all these things are very, very important, and hence a good imaging is very essential before doing the biopsy. Now, once we have done the biopsy, you have the histopathological diagnosis and distant extent of the disease. Now you combine them together and you stage, or you put your patient into a particular stage. Now there are a couple of staging systems for malignant bone tumor, and the most common used is AJCC classification, but it is a bit complex, which involves the primary tumor site, regional nodes, and metastatic site, as you all know. Essentially, if you have a tumor which is less than 8 centimeter, it is considered as T1. If you have a tumor which is more than 8 centimeters, considered as T2. And if you have skip lesions in the same bone with a normal intervening marrow, these are considered as T3 lesions. Similarly, if you have nodal metastasis, they will become N1. Metastasis only to the lung, they behave better than metastasis to bone or brain or any other part of the body, and hence the lung metastases are categorized into M1A, and if they're on any other side, they're categorized into M1B. So this is how this AJ system works, and then you have a grouping according to which you can stage your patient and then can plan your treatment and the prognosis. A simpler version, which was given by Musculoskeletal Tumor Society, which was also called as Enneking classification system. It's pretty simple, and it's essentially based on the grade of the tumor. If your tumor is low grade to intermediate grade, it comes in stage 1. If you have a high grade tumor, it becomes stage 2. Now, if your lesion is within the bone and it is not going outside the bone, so that means there is no extra osseous mass, it becomes type A, whether it is 1A or 2A. But if you have a lesion which has gone to the different compartment, it becomes type V. So similarly, you have 1B and 2B. And any kind of metastasis, whether nodal or regional nodal or distant metastasis within the bone or the lung, are classified all together as stage 3. So this may not be very correct in terms of classifying the treatments and the further details of the treatment, but broadly to remember, this is a neat classification and is practiced pretty widely by most of the surgeons. Now, what is the importance of the staging? Staging is essential to guide you to two very important questions, which you will be asking yourself while treating a patient, or patient is going to ask you. Number one, what is the prognosis of this patient? And based upon that prognosis, what sort of treatment you will be offering? And this is all guided by the staging, and hence you must complete your staging before embarking onto any sort of treatment. A few more points which are very, very essential here. And before I embark on to the treatment per se, I would like to highlight on this slide, and you can see that whether it's malignant bone tumors or soft tissue sarcomas, surgery is only one component, and you also require help from your radiotherapy and chemotherapy colleagues for the treatment. So what essentially it means is that you as a surgeon or anybody or anybody as a medical oncologist or a radiation oncologist alone cannot treat malignant bone tumors. It is the multidisciplinary team and the multidisciplinary approach which helps you to have a correct diagnosis and also to treat these patients. And hence, there are various guidelines which talks about the importance of MDT treatment, and they classify into core groups and the specialists require. And there is enough literature which talks about that the patients who are treated at multidisciplinary centers has much better outcomes as compared to the patients who are treated in peripheral discrete centers where MDT teams are not available. So I think Vivek had asked me in between whether we can stop in between and take some questions. So here I have completed the evaluation and the staging part. So maybe if there are any questions, or if Vivek wants to ignite any sort of discussion, we can spend a couple of minutes here and then I can go further.
So, sir, I was actually going through the talk, and you have very beautifully covered the sequence. And I think it's very important across specialty, not just for surgeons, but everybody to know the sequence. I just wanted to, probably it is jumping the gun, but what happens when we get a patient who has already been biopsied outside before a imaging? Because many times, you know, and me and Vivek know that many times we get a patient who has already been biopsied without a imaging. So how to interpret imaging in those patients when you know that there might already be a hematoma or the field may already be contaminated?
So Dr. Garg has highlighted a very important point that if you have done a procedure before doing the imaging, there will be a lot of artifacts or there will be a lot of changes in the imaging which you will get. Because of the trauma of the procedure which you have done, and especially, you know, most of the time people who are not trained, they do open biopsies, which leads to hematoma and there is inflammation. So it is extremely difficult to assess the disease. What we can do is that you do one imaging now, look at the T1 sequences, because they will differentiate between edema and the real disease. And then maybe later on, once you start maybe the neoadjuvant treatment, or give a gap and then redo the imaging and compare both the imaging, then you will be able to assess the lesion better. So that's how we do it.
Yes, sir.
Okay.
One more point, sir. You highlighted it that we need to have clinico-radiological and pathological correlation. And what do we do sometimes if the lesion looks aggressive, but our biopsy does not show any sarcoma, or it shows just non-histological type of diagnosis? Do we repeat the biopsy, or we just discuss based on the radiological imaging? So please, can you highlight this?
Thanks, Vivek. So this scenario often happens, and there are specific reasons for it. Sarcomas are heterogeneous lesion. If somebody has not been very careful in identifying the right areas and targeting those areas for biopsy, you may end up getting necrosis. You may end up getting low-grade tumor samples, and hence your clinical picture may not match with the histopathology which you are seeing. So if there is discordance of this sort, I will advise that you do an image guided biopsy and target the specific areas, and repeating a needle biopsy is not a very difficult thing to do. But if you are repeating it, then it will be advisable that you do image guided, whether it is ultrasound guided, whether it is CT scan guided, or it is image intensifier guided, depending upon the lesion, so that you can target the right areas and then rediscuss them into MDT with the help of radiology and pathology colleagues and get to the correct diagnosis.
Right,
And
sir.
sometimes, rarely, sometimes what happens that in cystic lesions or in some difficult intermediate grade lesions, even after doing couple or three of needle biopsies, you may not be able to come to a consensus based upon the comparing the history and examination and the biopsy. You may require to do an open biopsy, but that's a very, very rare situation. And in TMH, we do open biopsy for maybe less than 1% of our patients.
Right, sir. And I think there is a question from our audience, and both the questions are related to PET scan. One is the role of PET scan versus CT thorax and bone scan, though they have not specified the histology.
Okay.
And the other question is PET scan a good investigation for osteolytic lesions? So that is, I think, something abroad. So, sir, just can you briefly highlight about the role of PET scan in MSK oncology?
Okay. So again, a very debatable question, and a lot of people get confused, but actually there's nothing to get confused. So the standard of care for staging an osteosarcoma lesion is to do a non-contrast enhanced CT scan of the chest with thin slices and to do a bone scan, which is always available at all the centers. Doing a FDG PET scan is not a bad idea at all. And FDG PET scan or a fluoride 18 PET scan will also pick up the same amount of the disease. But as I mentioned earlier, that in most of the centers across India, PET scan will cost maybe twice or thrice the amount of the money which a CT scan and a bone scan will cost. So it is, in PET scan, you might be able to pick up maybe a few more METs, but that will not make a difference in the clinical management. So your output is same, but you are paying much more for the same output. So the decision is yours. I have had few colleagues who said that in my center, doing a CT scan of the chest and a bone scan costs the same as PET scan because we have subsidized. No problem. Please go ahead with PET scan. There is nothing wrong in PET scan. But in most of the center, it is cost more. That is the only difference. Now I will talk about Ewing sarcoma. Ewing sarcoma, traditionally, we have been staging with CT scan of the chest and bone scan like osteosarcoma. In addition to that, we have to do invasive bone marrow biopsies from at least 2 different sites, which may be the posterior superior iliac spines or maybe the sternum. Now, there's a lot of data available which talks about the efficacy of PET scan to pick up the marrow disease in Ewing sarcoma, because Ewing is considered as a marrow disease. Now, there is a lot of data which shows that whether you do these invasive biopsies or you just do a PET scan, the outcomes are almost the same, and PET scan is pretty good in picking up the marrow disease. So the thing changes. Here you are avoiding 2 invasive procedures by doing a PET scan. Ewing sarcoma is most common in first decade and in second decade. So most of the population, your patient population is pediatric, which will require anesthesia to do this invasive procedure. So even if you look at the cost benefit ratio, maybe PET scan serves better. And obviously you don't have to do the invasive procedures. So rather than posting a patient for a CT scan, then for bone scan, and then for invasive biopsy, just do a PET scan and it is done. Third is chondrosarcomas. Chondrosarcomas metastasize very, very rarely. And in my recent publication, which we just published in CORR, clearly shows that if you do not have a multiply recurrent or patient with pathological fracture, the chances of getting isolated bone metastasis is less than 1%. So hopefully our paper will be quoted very extensively, and it will change how various guidelines talk about staging chondrosarcomas. So that's the take on PET scan.
Thank you, sir. So I think there are no more questions. We can go ahead with the next part of your talk.
Okay. So till now we discussed about how we need to evaluate these patients and how we need to plan our treatment. Now, the treatment needs to be planned in a particular sequence, because when done in a particular sequence, it helps you to provide a better treatment with better outcomes. Okay. In malignant bone tumors, specifically in osteosarcomas and Ewing sarcomas, you always sandwich your local therapy between neoadjuvant and adjuvant chemotherapy. Okay, so it's a sandwich treatment which has happened, and obviously you need to reassess these patients after completing your adjuvant therapies and then follow them further as well. So hence we need to treat them in a particular sequence, and there are specific reasons for it. Now let's discuss malignant bone tumors one by one, and what are the main roles of these 3 subspecialties in the multidisciplinary management. When we talk about osteosarcoma, surgery is very, very essential to take out the tumor completely. I'm again repeating, to take out the tumor completely. There is no role of doing intralesional surgery or or margin positive surgery in osteosarcomas, you must remove the tumor completely with wide margins. Chemotherapy is very, very essential because it has raised the outcomes to a great extent, and I will be discussing that in further. Radiotherapy has a very, very limited role in the management of osteosarcoma, especially in the resectable osteosarcomas, and is only utilized for palliation. And how the new modalities have changed, I'll be discussing after maybe 10 minutes. When we talk about Ewing sarcoma, things are slightly different. Surgery has a very major role, again, especially in the extremities. But if you have tumors which are in the axial skeleton, these tumors are more radiosensitive, and definitive radiotherapy can also help you to achieve good outcomes when the morbidity of the surgery is very, very high. Again, chemotherapy like osteosarcoma is extremely essential and must be given. In addition to that, adjuvant radiotherapy in Ewing sarcoma also has a very definitive role, and we will be discussing the indications after a few slides. Chondrosarcoma is essentially a surgical disease to be treated with surgery only, as these tumors are chemotherapy and radiotherapy insensitive. So with this background, let's see how we go further. Let's talk first about surgery, and then we'll talk about chemo, and we'll talk about RT and how this combine together to optimize the treatment. Surgery considered to be the best modality for local management of these tumors. Broadly today, I'll be just touching upon what sort of surgical options are available, and maybe after a few weeks, when we have a detailed class on limb salvage options and surgeries, I will show you more details. So what you need to basically understand is we need to remove the tumor completely. In most of the instances, we can remove the tumor with a wide surgical margin and can still save the limb, where we call it as limb salvage. Unfortunately, there may be some indications where we cannot salvage the limb, and hence we have to do amputations. But we must always remember that oncological aspect is always weighed higher than the functional aspect. We cannot say that I want to give good function to this patient and I am a compromise oncologically. That will be absolutely wrong. Howsoever good your reconstruction may be, if your oncological aspect is inferior, if your margins are not adequate, these patients will get local recurrence, and again they will end up with amputation, and most of them may lose their life as well. When we talk about limb salvage, again it is divided into two steps. Step one, where you remove the tumor completely with wide margin, and step two, where you reconstruct those defects, those bony defects, so that your patients can have a good functional outcome. Now, before we go further, I will just touch upon that what sort of margins we talk about in surgery. We always keep talking about wide margin, wide margin. What exactly is this? So again, Musculoskeletal Tumor Society has spoken about 4 margins. The first one being the intralesional, where you go inside the tumor and curate it. Such type of margins are practiced in benign tumors like giant cell tumor, chondroblastomas, aneurysmal bone cysts, etc. If you have ever done a lipoma excision, where you just go around the capsule of the disease, it's called as marginal excision. Again, not very popular or not to be done for malignant bone tumors, because around the capsule in the reactive zone, these patients may have the satellite nodules of the disease. And hence, you need to practice what is called as the third type of margin, or the wide margin of resection, where you take out the tumor completely along with a cuff of normal tissue around the disease. And hence, you take out the tumor along with the reactive zone and a part of normal tissue. And hence, wide surgical margin of resection is practiced for most of the limb salvage. If you are removing the entire compartment, it becomes a radical excision and hence an amputation. So again, what should be the adequate margin when we talk about wide margin? We always assess the disease, intramedullary extent of the disease, and we take additional 2 to 3 centimeters of the bone, which is considered as adequate for the bone. When we talk about the periphery in the soft tissues, we always talk about Kawaguchi system, where a good fascia cover is good enough. We can be focally close to neurovascular bundle, that is fine, and it doesn't increase the chances of local recurrence. Nowadays, a lot of new research is being happening, and we are trying to combine the effect of the treatment which we are doing and to see whether how close or how far we should be. This Birmingham classification is a great example, published by a dear friend Lee Jays from Birmingham, and a couple of years back, where they have combined the necrosis because of neoadjuvant chemotherapy and looked at the margin, and they have clearly shown the tumors which have responded very well to neoadjuvant chemotherapy, you can be closer in margins, but the tumors which have not responded to chemotherapy or tumors which have increased on chemotherapy, you should be very, very careful in assessing them and doing a limb salvage, and your margins have to be really wide. And this will lead to more local failures if not practiced, and hence inferior outcomes. So once you have resected your tumor and you have these big defects, you need to reconstruct them. And you require various type of modalities, which should give you a durable sort of reconstruction, which should be good to look at, functionally good, and can stand for a long period of time and can be easily done. And one of the best possible examples are the non-biological options available, where we do endoprosthesis or megaprosthesis for most of our osteoarticular resections. Sometimes where we have to do extraarticular resections, or in patients who have poor prognosis, we may also do spacers as well. Just to show you one of the examples, just to touch upon, this is a high-grade surface osteosarcoma which arises in the distal femur. After giving neoadjuvant chemotherapy, this tumor was excised and was reconstructed with tumor endoprosthesis, as you are seeing in this picture, post-operative X-ray. These are the follow-up X-ray at 4 years, and you can see the function, which is pretty good. Very difficult to say which limb is operated, and this patient is doing all the activities of his daily living. And now with the help of better and better prosthesis, the longevity of these prostheses is also pretty long, and the functional outcomes are pretty good. Apart from these non-biological options, we have lots of biological options, and countries like us where cost is a big concern, these biological options have given us a lot of liberty to give good reconstruction for our patients. Now there are a list of options available, like for example, you can use patients' own bone grafts, which are autografts. You can use allografts, which are available in the bone banks, like we have in Tata Memorial, and a lot of bone banks are also coming up all across the country. You can use buddy bone transfers. I coined this term because I really like this term, buddy bone transfer, especially like tibialization of fibula and ulnar translocation. If you have to resect the tibial tumors or radius tumors respectively, you can do these buddy bone transfers. You can also do free fibula transfers, which can be alone if you are doing for the upper limb, or it can be in combination with the allografts, like Kapana's technique, which specially used in the lower limbs in the weight-bearing areas. One of the very important areas which has developed is the using patient's own tumor bone after re-sterilizing it, and we have been practicing it since past almost 15 years now. And this initial part of our study, we were sterilizing the bone with radiotherapy. It's called as extracorporeal radiotherapy. And now we have started using cryotherapy and pasteurization for it. And this is one of the examples where this is one of the examples where we had a patient of osteosarcoma of the femur. This is the 8-year follow-up of this patient. He has a bit of shortening because he was a kid when we did that. But this bone has united pretty well, and he's absolutely fine now, and hopefully this will survive lifelong. So this was essentially extracorporeal radiotherapy and reimplantation. Pelvic sarcomas are a big challenge to reconstruct. There are a lot of options like using allografts, patient's own sterilized tumor bone, or there are various prostheses available. But now more and more data is coming, and it is supporting the kind of surgeries or the reconstruction which we have been doing since past 2 decades, and especially with the Euro-Ewing trials, which talks about role of radiotherapy in almost all Ewing pelvis sarcomas, where again having the less amount of metal and doing mesh plasties or pseudoarthrosis with mesh plasty has again come into vogue, and these patients have fantastic function. So this is an example of Ewing sarcoma of a kid, and this is a 7-year and and a 12-year follow-up of this patient, where it is very clearly shown that even without having this hemipelvis, this kid can almost do everything. No amount of metallic prosthesis will give so much of liberty and such a great function even at a 12 to 13-year follow-up. So meshplasty is coming up in a big way, and this is a very good option for reconstruction of pelvic sarcomas. Recently, we have started using navigation and patient-specific instrumentation for the resection of these difficult tumors in difficult locations. We've completed about 22 cases of pelvic and sacral resections with the use of navigations, and we feel that our early results have shown that computer-assisted tumor surgery helps us to decrease the blood loss and help us to decrease unnecessary dissections, and we can achieve better surgical margin in difficult cases as well. So hopefully in few years to come, we will be coming up with more data onto this. Now we have a lot of options available, but what we need to remember is that it has to be customized for each and every patient, and there are various factors which you need to understand and take into account while deciding the options. You need to look at what sort of tumor you are dealing with, whether this tumor will require radiotherapy or not. Where is the exact location of this tumor, whether it will take out the joint or it will take out the physis or not. What is the age of the patient? Is the patient pediatric or adult patient? So there are a lot of different sort of reconstructions available for them. What is the expectation of a patient, whether it's a white collar job where he just want to sit on a table and chair and do the work, or he's a laborer or a farmer who has to go to work in the fields every day. And also very important is what is the surgical expertise and the infrastructure available. All these factors guide us to find the best possible option for a particular patient, and then we should execute it. So this was about the surgery, and quickly I will take you through the role of chemotherapy and radiotherapy in the management of malignant bone tumors. This graph is self-explanatory, which clearly shows the difference in the outcomes of the patients with malignant bone tumors before the chemotherapy era and after the chemotherapy era, where the overall survival outcomes have increased from merely 15 to 18% to almost 65 to 70%. And hence, chemotherapy is must in the management of malignant bone tumors, specifically osteosarcomas and Ewing sarcomas. As I discussed earlier with you, that most of the time we sandwich local therapy between neoadjuvant and adjuvant therapy, and I'm sure all of you know what it is. Almost all of you also know that neoadjuvant chemotherapy helps us to control micrometastasis. It decreases the vascularity of the tumor. Surgery becomes much easier. If you're planning to do some fancy customized prosthesis, want to import some prosthesis, it gives you some time to do that. And obviously, very important that you will get to know a very strong prognostic marker, that is the response to the neoadjuvant chemotherapy on histopathology, which will be able to guide your further treatment if you want to change it, which actually doesn't make any difference, but also to tell the patient what is the prognosis. There are few disadvantages, but all these are debatable. Like, for example, development of some drug resistance, high tumor burden. If you get some complications, or it may delay your local therapy. Some tumors are not responsive to neoadjuvant, so they may grow. But the argument is that if the biology is so aggressive that it is not responsive to neoadjuvant chemotherapy, then irrespective whether you treat them or not, they're going to behave bad. So I'm going to skip this, and I'm going to take you to the protocol for osteosarcoma chemotherapy, which is practiced at Tata Memorial Center. For chemotherapy of osteosarcoma, you have two regimes available. One is IAP regime, which we practice in Tata Memorial Center. This is a non-methotrexate based regime where we use adriamycin, ifosfamide, and cisplatin in 8 cycles, 4 before and 4 after the surgery in various combinations, as you can see here. There is another regime called as MAP regime, where we replaced ifosfamide with methotrexate. That's again a fantastic regime. Globally, most of the centers where you can admit the patient, where you can hydrate the patient well for each cycle, where you can measure the methotrexate levels, that is the preferred regime, especially in pediatric age group. Adults may not tolerate it that well, and again, you might use IAP regime in adults. But both outcomes, there is no head-to-head comparison or randomized control, but globally it feels that a MAP regime is slightly better and have different kind of toxicity profile as compared to IAP, and hence preferred in young adults and pediatric age group. So let's talk about a bit about Ewing's chemotherapy. Again, your local therapy, whether definitive surgery or radiotherapy, it is again sandwiched between the induction chemotherapy, where we use alternative cycles of VIE and VAC, and then later on we may add actinomycin D, and then which acts as a adjuvant chemotherapy, or we also call it as maintenance chemotherapy. The duration of chemotherapy is pretty longer in Ewing sarcoma, and I'm sure you can discuss with your colleagues in detail, and the protocols were pretty available, easily available, and obviously this has to be practiced by the expert medical oncologist under proper care. What I want to highlight here is that neoadjuvant chemotherapy actually reduces the tumor bulk, both in Ewing's and osteosarcomas. It sort of decreases the extraosseous soft tissue component or solidifies it, decreases the vascularity, and hence your chances of getting an appropriate margin, doing a good surgery with blood loss increases, and hence NACT has become a norm even for this, and is preferred by the surgeons. Once you have resected this tumor specimen, you should be very, very careful to evaluate all of your specimen very carefully for two things. Number one, your margins of resection, and number two, the response to the chemotherapy. Response to the chemotherapy are essentially can be graded by Hugo's system or by Pitchy grading system, and essentially we divide them into good responders and poor responders. Hugo's grading system, as we are showing here, any necrosis which is 90% or more considered as a good response, and these patients will have a better outcome as compared to the patients who have less response than the 90%. Hugo's grading system can also be used for the Ewing sarcoma, but there were head-to-head comparison which were evaluating the Pitchy's grading system and found that Pitchy's grading system is more relevant for Ewing sarcoma, and hence it is more popularly used. Here, apart from 3 grades, we have, apart from 4 grades, we have 3 grades. Grade 1, where you can see the macroscopic disease. Grade 2, where you see few isolated microscopic nodules. And grade 3, where you have complete tumor necrosis, and hence the prognosis also varies. So the importance of necrosis, the higher the necrosis, better the survival. In TMH, we also evaluated the patients with 100% necrosis and less, and we found that the 100% necrosis patients will have better outcome than the patients who had between 90 to 99 as well. So looking at the prognostic factors in malignant bone tumors, apart from response to the induction chemotherapy, which I just discussed, we also know that the metastasis on presentation is a very strong prognostic factor. Patients with isolated lung metastasis will do far better than the patients who has bilateral lung metastasis or have bony metastasis. Tumor size of more than 8 centimeters is always thought to be a bad prognostic marker. If you have a tumor in the pelvic or axial location where resecting the tumors with wide margins may be complicated, those patients may have higher rate of relapse and has inferior outcomes. And again, as I discussed earlier, that the complete surgical removal of the disease is again very important, and if not done, is a poor prognostic factor. Coming to the role of radiotherapy, in osteosarcoma specifically and in extremities, the role of radiotherapy is very, very limited. It is considered for margin positive cases where you have again advice for the surgery which may be ablative and patients are not ready to undergo that. Or if you have if you want to do palliative pain control, radiotherapy is pretty helpful. But for unresectable axial skeleton tumor, we have now newer modality which are higher heavy ion therapies, which are essentially proton beam therapies or carbon ion therapies. Japanese are the pioneer of this therapy, and now these are available in quite a few countries. In India at present, it is available in Apollo Chennai, and Tata Memorial is also starting in maybe in a few months from now. And it has been seen that with the help of carbon ion and proton beam therapy, these unresectable osteosarcomas have good local control, and these results are pretty published. And now this is being used very regularly for sacral chondrosarcomas as well. As I discussed earlier, that the role of adjuvant radiotherapy in Ewing sarcoma is much more pronounced as compared to chondrosarcomas or osteosarcomas, and indications for doing adjuvant radiotherapy in Ewing's are having a positive margin, or if you have done a planned close or positive margin, if you had a marginal resection by chance, if you had a very large volume of the disease to start with, or your patient had a pathological fracture. So if you have these kind of indications in your patients of Ewing sarcoma, you might add an adjuvant radiotherapy to improve the local outcomes. Now, a few slides about different kinds of osteosarcoma. Parosteal osteosarcomas are essentially low-grade osteosarcomas, and this is a hint of one of the MCQs which Vivek has asked you, that these tumors do not require chemotherapy, and doing a wide surgical resection is pretty good enough. But very important is that you assess the specimen later on after excision, and if you have any dedifferentiated areas, this patient should be given chemotherapy. Periosteal osteosarcomas are intermediate osteosarcomas between high grade and low grade. The role of chemotherapy is pretty debatable. Globe is divided into two thoughts, whether they should be giving toxic chemotherapies or not. Other people think that whatever benefit it has, we should give. So essentially, we don't have the right answer, but people think that if you have the invasion of the marrow and large tumors, people end up giving chemotherapy for periosteal osteosarcomas. These are essentially cartilaginous differentiation of surface osteosarcomas. Now, these are, I will end with these few slides. These are the algorithms which we practice at Tata Memorial Center. These are very easily available on the websites. You can go to the website of Tata Memorial and these are there. Even IMSOS guidelines are also very similar, and these are freely available on the IMSOS website as well. So these can be a very good guide in your clinic to look at the overall treatment algorithm. And these are for osteosarcomas and Ewing sarcomas, where we have mentioned about chemotherapy, radiotherapy, adjuvant as well as definitive, and also for the chondrosarcomas as well. In chondrosarcomas, if you have a dedifferentiated chondrosarcoma, we must add an osteosarcoma-based chemotherapy line for these tumors. And a very rare variety, that is mesenchymal chondrosarcomas, essentially are the round cell chondrosarcoma with large component of round cells. And these patients have very poor prognosis, but still should be given a round cell chemotherapy, that is Ewing's chemotherapy in mesenchymal chondrosarcomas. Now, once you have done this all treatment, please do not lose your patient. Please guide them properly and ask them to come for the follow-up, because surveillance is extremely important for the management, looking at the assessing your patient for the toxicity, as well as also for local and distant relapses. You may call your patient more frequently in first 2 to 3 years, because the rate of local and distant failures is much higher in first 2 to 3 years. Essentially, all tumors may be followed for 10 years. In first 2 to 3 years, you may call them anywhere between 3 to 6 months, doing various sort of investigations. And then later on, after 5 years, you can call them once yearly. You must look for the toxicity because of the all kind of treatments, whether it is surgery, whether it is chemotherapy, or whether it is radiotherapy. And then these patients also require a lot of psychological support, which has also become very essential part of your surveillance follow-up. So I think I'll end here. So this was the whole treatment plan, right from seeing a patient with a suspected lesion in the bone till you do the long-term surveillance for 10 years. And I hope I have been able to make things a bit clear for you guys.
Thank you, sir. And in fact, it was a very comprehensive coverage of this extremely difficult topics, right from diagnostics to the management principles. So I think there are a few questions, so we'll take up on that. And one of the question is, it is about upfront surgery in osteosarcomas. So, sir, in which conditions do you plan for upfront surgery in osteosarcoma?
So as I mentioned earlier, that neoadjuvant chemotherapy has become a norm, and I explained you the obvious reasons. But if you have a patient who has a large fungating mass where you cannot give chemotherapy, or if you have a very elderly patient which has a compromised heart and you cannot give chemotherapy as such, so in those contraindications, you can go ahead and do upfront surgery and then maybe reassess these patients whether they get fit for the adjuvant chemotherapy or not. But that's not going to change outcomes essentially.
Right, sir. So another question is there, like we spoke about percentage necrosis after chemotherapy. So do we change the regimen if there is poor necrosis because of particular chemotherapy? Suppose if it is IAP and now there is poor response to that and the percentage necrosis is 70 or 80. Do we change it to MAP protocol? Does it help?
Okay, so I will divide this question into two parts. Number one, if you are giving 3-drug therapy, or if you are giving any inferior, maybe like 2-drug therapy. So if you are giving 3-drug therapy, whether MAP or IAP, there is no literature which supports change of your any kind of agents. Like for example, if you are giving IAP and if your necrosis is less, adding methotrexate doesn't add to survival at all, and vice versa is also true. There is some studies, few literature where the authors have used 2-drug chemotherapy to start with, maybe cisplatin and adriamycin. Those are the 2 drugs which are mostly used. And in poor responders, people have added methotrexate or ifosfamide and have shown a bit better outcome. But those are anecdotal studies, globally not acceptable. So essentially, if we have to put it very clearly, there is no advantage of changing therapy after necrosis. And another point which people also talk about is that you don't want, in case you have a failure, maybe after 12 to 18 months, at least you want to leave with few agents if you want to try as a salvage therapy or a second line therapy. So these are the rationales, but mostly on the globe, people don't change it.
Only if it is 2-drug regimen or something inadequate chemotherapy, then
they add up a third.
Right, sir. There is another question, and that is about Ewing sarcoma family of tumors, like Askin's tumor. The question is about, can you throw some light? So which is Askin's tumor is basically chest wall Ewing sarcoma. So the management protocols is the same, how we treat Ewing sarcoma, or is there any different modalities like more of radiation, or same we give chemo or surgery?
So the principles of Ewing sarcoma anywhere in the body, whether it's head and neck, whether it's Askin tumors or pelvis or spine or extremity, the principle of management remain the same. If you can surgically excite the tumor with wide margins and the morbidity is acceptable, you take the tumor out and you may back up with radiotherapy depending upon the indications of adding up adjuvant radiotherapy. The issue with skin tumors is because they are in such a difficult anatomical location, it is extremely difficult to get the wide surgical margins, and hence most of the skin tumors will have either a marginal resections, and they will always be backed up with definitive radiotherapy. And I think this is the reason why they have inferior outcome as compared to the extremity Ewing sarcomas. But the principle essentially remains the same.
Shubham, do we have more time? Because already we have short.
No. We have more time. There are some more questions, I think.
Yeah.
Here.
Yeah, go ahead.
So there is a question, I think, which is based on the Birmingham classification.
Okay.
What exactly do we mean by that classification, which takes into account both the necrosis and the margins?
Okay. So Birmingham before Birmingham classification, we always used to say that, so there's paper from one of the from Sloan Kettering when Jay Wonder was doing his fellowship, and it was his study from Sloan Kettering which talked about that lesser the necrosis, more are the failures locally, and then you have the lesser outcome. And there were other papers which talks about that if your margin is 2 millimeters or less, then the rate of local failures are still high. But nobody had compared how patients happen if you categorize them into different categories where you have a combination of I'll just show you where you have a combination of low necrosis and close margin. Second combination was higher necrosis, close margin. Higher necrosis, wide margin, higher necrosis, and close margin. So basically, you are trying to combine the two negative factors and trying to see whether the effect is more worse or not. And that's what exactly happened. So if you have a tumor which has not responded nicely to chemotherapy and you have a close margin, that patient will have a much higher chance of local failure as compared to a patient who had a good margin of resection and had a better necrosis. So this is Birmingham classification, which actually combines two negative factors, two prognostic factors, and try to assess the local recurrence rates. And local recurrence rates essentially in malignant bone tumors are equivalent or signifies the overall survival. So this is Birmingham classification.
Right, sir. In another question, like we discussed that in low-grade osteosarcoma, like parosteal osteosarcoma, the question is based on final histology, sometimes do we change the plan of modality, like we add any chemotherapy? Though the question was like percentage of viable tumors. So what is your take on that?
So that question doesn't arise. If you have not given any neoadjuvant chemotherapy in parosteal, where is the question of necrosis happening because of chemotherapy? So it is very clear. Parosteal osteosarcoma is a low-grade disease. There are two kinds of osteosarcomas which are low-grade. One is intramedullary low-grade osteosarcoma, which is extremely rare to find. And second is the parosteal. Both of these are low-grade pathologies. Sometimes parosteal osteosarcomas de-differentiate into higher grades, and that will only be possible when you assess the entire specimen after excision. So if you have those areas which are clearly high grade, then you add up chemotherapy, otherwise not.
Right, sir. So I have one question, sir, because we face this situation many times in our
You have
practice.
question? Okay.
So this is for the benefit of our audience, because many of them are residents, and once they start practicing, many a times we see patients coming to us with FNAC reports about a diagnosis of tumor. So how do you take on that? Do you accept FNAC in the diagnosis of bone tumors or soft tissue tumors or not?
So if I have to put it like a teaching or even for the medical legal case, there is no role of FNAC in diagnosis of a bone tumor. It is very clear. It's absolutely clear. FNAC has very specific roles in picking up recurrences. So if you have some cells, they will show you what kind of morphology they have and whether they have ATP or not. But if you really want to have the diagnosis, if you want to do ISCs, if you want to do your molecular studies, you need to have a complete histopathological examination, which includes morphology. You need to evaluate them in detail and then give a correct diagnosis. Just having FNAC saying it is a giant cell lesion or it is looks like atypical mitosis, so sarcoma, that doesn't hold good. So let's not debate on that. So FNAC, no role. Only role is if you have already diagnosed tumor which has a failure or nodal metastasis, something, we just want to see whether there are malignant cells or not, which matches with your previous diagnosis. That's it. Keep it as simple as that.
And another similar situation, many times we see that orthopedic surgeons, they say that we plan to send frozen for the diagnosis. So is there a role of frozen in the diagnosis of bone tumors when we are planning any definitive surgery?
Even the best of the pathologists in TMH globally, they are very, very varied on giving you a correct diagnosis on frozen section. So please, please do not manage your patient only on frozen. The indications are extremely limited. And I think people who practice bone tumors day in, day out, only those should explore those indications. For teaching purpose, please do not rely on frozen sections for doing a definitive treatment. Yes, you want to see the adequacy of the biopsy. It's a very good technique to show whether your biopsy is adequate or not.
The next question, already you have emphasized very well about the margins, but it is always which is not well understood by everyone. So again, one of our audience wants to know what is the optimal margin for bone resection? 2 centimeter, 3 centimeter. What is the optimal margin?
So this is a very difficult question to answer, because if you would have asked me this question about a decade back, I would have given some other answer. We are evolving, every day. If you would have asked somebody in 80s, the answer would have been different. But the reason and the principles are same. Okay, and the reason and the principle is that you want to remove the tumor completely. That is the base or the principle of it. Now, earlier, we were not having very accurate imaging modalities. So in 80s, people used to say we should take 5 centimeters margin or 6 centimeters margin. Okay, because most of the sections were on a very low grade MRI or CT scan. So margin of resections were a lot. Now with the advent of better and better imaging, we have started getting closer and closer. And we have seen in our studies that even carefully planned 1 centimeter margin of resection is pretty good. But as a standard of practice, we always say that take a couple of centimeters or 3 centimeters. Excising 1 more centimeter will not make a difference. The difference comes where you can save a physis, where you can save a joint, patient's own joint. There you have to be an expert. You need to assess all sequence of the MRIs very, very carefully. You may have to discuss with the radiologist. You may have to compare the pre-chemotherapy and post-chemotherapy MRIs, really look at the resection margins. And then maybe if you have better technologies like navigation and stuff, then execute your surgery very, very perfectly. So those indications are limited. But if I have to say for the students and for everybody, practice 2 to 3 centimeters of margin in the bone. You can be close based upon the scenario, but principle is same. We need to take out tumor completely, including the reactive zone.
Right, sir. So I think we have covered all the questions. Shubham?
Yeah. So there is one question on the YouTube channel which both of you can't see. So that question is basically on Mirrell staging. So we can cover it actually. What are the components of Mirrell? criteria, and we can do that when we go through the questions also.
I think Vivek can do that, but I just want to say that you need to clearly understand that Mirrell is for the impending fracture, and it is not for the management of sarcomas. So that should be clearly stated.
Okay, okay. I think we have had a wonderful lecture. We started with only one off class with Dr. Gulia and planning to cover limb salvage as the question was. But what it has evolved into is now a series of lecture where we are covering the whole gamut of bone and soft tissue tumors, and we are very thankful for Dr. Gulia sir that he has taken the lead in this, and he's hand holding us like always in navigating through the navigation that he does so beautifully in the last 25 cases, as he's telling, to navigate us through the sea of bone and soft tissue tumors with a good margin, and we'll ensure that we get good results. So thank you, sir. It was a very informative session. Is Dr. Geeta around? Dr. Geeta, can you?
Last question.
Yeah, I can hear you.
Sir?
I can hear you.
Okay.
Yeah.
Sir,
Thank you,
last
Dr.
question,
Gulia.
sir.
I have nothing to do with bone tumors or soft tissue sarcomas anymore. But I quite enjoyed your talk because, yeah, so at the time that we used to do all of it. So I still remember, necrosis, yes, but this is very interesting when you talked about margins combined with, with necrosis. So that was quite interesting. We did a quiz in the beginning. I'm sure Vivek conducted that quiz. And so it'd be good if Vivek can go through the answers, and I'll let you know how many participated and who got it right.
So, Dr. Gulia, just stay on with us till the quiz gets over, because if there's any question that we feel you can probably explain us better, it will be nice. Vivek, can you go ahead with the answers, please?
Yeah, so the first question was, which is an absolute contraindication for limb salvage surgery? So we know that broadly there is a strike, there's a 3 out of 4 rule that if there is involvement of bone, nerves, vessels, or soft tissue, if 3 out of 4 is involved, then it goes for amputation. But now in the current situation in 2020, when we have the availability of all the resources, we have a plastic surgeon and vascular surgeon, this is no more a rule so far, and these are all just relative contraindication for limb salvage surgery. So even if there is a pathological fracture, we have to assess after the surgery, after the chemotherapy. If it heals well, we can get adequate margins, then we can always go for a limb salvage surgery. Like I said, involvement of nerves or vessels can always be reconstructed. So the answer to the first question is none of the above. Right. The second question was 25-year-old boy with Ewing sarcoma with bilateral lung mets, 4 on each side. So of course, we know Ewing's is a systemic disease and chemotherapy should be started first. And nowadays, even with lung mets, if it can be resectable, or sometimes with good chemotherapy, even they dissolve, they can disappear with chemotherapy. And in such situation, we can hope for good outcomes. So the plan is not a palliative intent. It is always, we have to give chemotherapy, assess, and then we see. Many a times when the lung nodules disappear completely, we plan for local treatment followed by lung bath, or in case if they are resectable, we go even for lung metastatectomy. Third question. 20-year-old lady with parosteal osteosarcoma of distal femur with vascular involvement. So like just now, Gulia sir had shown that case with parosteal osteosarcoma, which is a low-grade type of osteosarcoma where we have to go for upfront surgery. And most of the times we can go for limb salvage with vascular reconstruction. And if for some reasons you are not able to do that, then amputation is the other option. So the fourth question is about Mirrell's scoring system, Mirrell's criteria. So this is used to assess the risk of developing a pathological fracture when there is a lytic lesion. Usually it takes into account the site of the lesion, whether it is upper limb, lower limb, or the pertrochanteric, the size less than 1/3, 1/3 to 2/3, or more than 2/3, the type of the lesion, lytic, sclerotic, or mixed, and then the pain, whether it is at rest, on
Right.
exertion, or activity. So the total scores comes around 12, which is the highest. Usually 7 and below are where the risk of fracture is less and we can observe. 8 and above requires a fixation because there are chances of more than 30% risk of developing a pathological fracture. So this is the second is the correct answer, the risk of developing a pathological fracture. And it guides towards a prophylactic fixation in such cases. Fifth question. So a 6-year-old boy with non-metastatic Ewing sarcoma of proximal femur, not the local treatment options. So of course, we know that in a sarcoma, we should never do an intralesional surgery, and rest all are the options which can be implied in these cases. So fifth is the right answer, that this should not be done, curettage and bone grafting. Thank you.
Sir, a question, sir?
Yeah.
Audible?
Somebody has a question. I
Hello?
think there was
Yes,
one
sir.
last question.
We can take that question. I think his
Sir.
question was on MRI, right?
Yeah,
Doctor?
yes, sir. Yes, 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 sir.
Just please ask your question, please. Go ahead. Go ahead.
Thank you, Ashish, sir, for your wonderful lecture series. Sir, we are taking the measurements for limb salvage surgeries based on the upfront MRI before starting of the chemotherapy. But what is the role of this MRI that we are taking after chemotherapy, that is before surgery? In what way it is going to matter, sir? Anyway, the measurements for limb salvage, the process has been decided based on the upfront imaging.
Sir, you are muted.
Hello.
Thank you, Dr. Bala Murugan, for asking this question, an important one. And so that's why when people ask me that which MRI you consider for measuring the disease or planning the surgery, my answer is not the pre-chemo MRI. My answer is whichever MRI shows me the maximum dimension of the disease, that is the correct answer. And why teachers earlier used to say the pre-chemo MRI? Because they always used to think, or we usually think, that these tumors will respond to chemotherapy. But many times we have seen that some tumors may slightly increase. There may be a delay in starting neoadjuvant chemotherapy. During that time, there might be some increase in the disease. Some tumors may not respond properly, but still they may be non-metastatic and we might have to do limb salvage surgery. Hence, you do both the MRIs, whichever MRI shows the maximum disease, depending upon that, you do your planning. I hope.
But always we face this logistic difficulties, sir. If we the time taken for making the custom made processes is quite a longer time. So we generally take the measurements based on the upfront MRI and give the order for prosthesis. So even if there is going to be some changes like progression of the disease, based on the post chemo MRI, it is a difficult situation for us to change the prosthesis again. So in that situation, how can we go about, sir?
How many patients you ask for a custom-made prosthesis?
So we are doing only custom-made, sir. Here.
Then I don't think so. That is the right answer, because most of the prostheses are off-the-shelf prostheses available. Now nobody makes custom-made prostheses for each and every patient. Most of the prostheses, most of the endo prostheses are available off the shelf. These are modular prostheses. Where on table you can decrease or increase the length, except for non-invasive expandable prostheses, which you are doing for growing children. There you have to do it, and there also you always keep a margin of plus minus in there. So I think that comes with bit of practice. But I don't think so you have to ask for customized prosthesis for each and every patient.
So I think the customization is to the length of the prosthesis, which we can decrease by every 1 centimeter. Am I right, sir?
Yeah. So there are modular prostheses available in all systems. Every system available in India has a modular system. So you really don't have to customize prostheses for each and every patient.
Okay, Dr. Geeta. So these were the answers, and what do you have for us then?
Okay, so you have a very elite attendance because bone and soft tissue sarcomas is not everybody's cup of tea. So you had a very elite group of 40 people attending this lecture. So we had 1/4 of them participating in the quiz, which is great because we don't get that kind of participation in our other lectures where the participation in the quiz is much lesser. But in absolute numbers, of course, we have more. We had 9 people answering the quiz, and only one person got all the questions right, and that is Dr. Avinash Rajra from Mahavir Cancer Institute and Research Center. And there were 3 others who got out of the 5 right. One was Dr. Atul Bharambe from Bharat Cancer Hospital, Surat. And the other person was Dr. Bharat Mishra from BCHRI, Surat. Yeah. And also Dr. Ankit from Cancer Institute. So that was, not bad, 1 all correct and 4 correct out of a possible 9 people who participated in the quiz.
I know that
so great going.
That is what is lovely about statistics. Sometimes we use the percentage, sometimes we use the absolute numbers. So
yeah, absolutely.
Okay.
I have a prize for the winner.
What is it, sir?
They can email me. I'll send them a copy of IMSOS guidelines free of cost.
Oh my God. Wonderful. So now...
So if Dr. Avinash Rajra is listening, so you have a treat, man. So, so we have been intending to always give a prize, but you have started it. I think now we need to, keep
so
that...
Now we'll put in the responsibility of the speaker to arrange a prize.
Oh, that's a brilliant idea you've given, Yeah, we should ask the speaker to,
And maybe Vivek can arrange a mega quiz at the end. And
yes.
The winner of the mega quiz, I will sponsor his registration for the next IMSOS meeting.
Wow, sir.
That will be great.
Yes. So now Vivek has some responsibility on his shoulders.
Or maybe I can make one for the surgical oncology, one for the radiation, and one for medical oncology. I can do that as well.
Great.
You're being very generous. I think you'll have a lot of takers, and I think the attendance next time is going to go up.
So the attendance, anyways, next time is going to go up because the topic that the speaker and the topic that this is what actually came from Dr. Gulia only, that he very kindly arranged that I told him that we don't want a surgical topic every time, and we would want a radiation topic or a medical oncology topic, and he was very prompt to speak with Dr. Lashkar himself, and Dr. Lashkar also readily agreed to take this lecture for us, and we thought that we'll cover the principles of radiotherapy in soft tissue sarcoma, although we are to send a formal invite to him, but in principle sir has agreed to it, so that is why we put it on this thing. But also next week Dr. Gulia will be back with us as a moderator this time to take the discussion in the right spirit and make it probably the little things that we miss, he will be able to highlight it for us. And sir, I'm sure we are taking a lot of your precious time on a Wednesday evening, but thank you so much for doing this for us. Thank you, sir.
Anything for you?
Dr. Balamurgan has just made a suggestion on the chat box and saying, arrange a topic on radiotherapy for CS cervix. So I thought he was saying radiotherapy for, soft tissue sarcomas.
So Dr. Bala, this topic is already, we have covered with Dr. Supriya Chopra, and it's available on our YouTube channel, which is Cancer Academy. So you can go in and have a look. And to everybody, that most of our topics are archived and they're available on YouTube. So we have now a library of around 15 YouTube videos, so which you can readily refer anytime. Okay. So, Dr. Geeta, word of thanks.
Shubham, for the next time, we can keep radiotherapy in bone tumors as well. Is it possible?
Yes, so that's...
along with soft tissue? Because there are some questions. Yeah. So some questions related to radiotherapy in osteosarcoma or even sarcoma. So we can include these in the bone tumors.
I'll speak to Dr. Lashkar. And what we spoke today was that he will take a lecture of 35 to 40 minutes.
Yeah, not a very long one.
Remaining 20 minutes, we can generate some case scenarios where we can have a discussion. So Vivek will also be there, and so we can have those discussions and we
Right.
can.
We'll have 3-4 surgeons presenting some case scenario. We can do this, sir. We'll invite, Michelle, or we can invite Suman to have one case each for us to discuss. Will that do, sir? That will be interesting. Make it interesting.
Yeah, but you have a very less time, and you need to make sure that all the cases are different. Sometimes what happens.
Yeah. No. So I'll sit with Vivek and we'll do that. Vivek will do that
Okay.
tomorrow,
Sure.
day after.
So I'll coordinate.
Yeah.
For that.
We'll speak with Suman and Michelle. That's not a problem, sir.
Yeah.
You have taught
And you
us.
must post the program in DMSOG, the Delhi Musculoskeletal Oncology Group, because I think, you'll get a lot of participation from there, because I think the next one is going to be as interesting as the one that was done today. And Dr. Ashish Gulia, I must congratulate you for the wonderful talk, but I must also congratulate you for the enthusiasm that you've generated. It keeps us also going, because to keep up the momentum, we always need this little push and this nudge. And I think
younger like Shubham, so
yeah. So, and because we're doing it for students, I think it's a great endeavor in that sense, because whatever you do for students, I think we all probably missed out on that because we did not live in such a technology savvy time. So we kept looking for things and not finding them, but now you look for it, you find it. So that's the difference between then and now. Thank you so much, and we look forward to interacting with you again next week, same time. Thank you, Vivek, for moderating the session. It's always a pleasure to have Vivek on board.
It was wonderful.
And of course, Vivek is a big gift for us from TMH. He's part of Max, and he's a great guy to have around. So he will be also back next time, and we'll look forward to that one. Bye-bye and good night.
Okay, bye. Good night. Thank you.
Bye.
Thank
Good
you.
night.
Thank you. Good night.